Okay, good morning all. I'd like to welcome you to Forensic Grand Rounds this morning. I hope that this presentation, this webinar finds you well this morning. This morning we're honored to have with us Dr. Zoe Hilton. Dr. Hilton is an associate professor of psychiatry at the University of Toronto, a registered psychologist, and a fellow of the Canadian Psychological Association. She was the lead investigator on the research team that developed the Ontario Domestic Assault Risk Assessment, a brief actuarial tool created to aid decision-making by police and other first responders to intimate partner violence. She's also led the development and evaluation of in-class and online professional training known as the Odara 101. Dr. Hilton has received competitive grants for her research totaling $1 million. She has received the 2010, Significant Contribution Award from the Canadian Psychological Association Criminal Justice Section for outstanding contributions to domestic violence risk assessment, as well as multiple provincial awards for teamwork and community service. She has over 130 publications in forensic mental health, risk assessment and communication, trauma among psychiatric workers and domestic violence, including the second edition of the book, Domestic Violence Risk Assessment, published by the American Psychological Association. Dr. Hilton is based at the Waypoint Center for Mental Health Care, and where she is currently a senior research scientist. So with no further ado, just one minor point before we have Dr. Hilton join us. Please hold your questions until the very end. Please just allow her to present, and then we'll present at the, or have time for questions at the end. So thank you for that. And Dr. Hilton, the floor is yours. Dr. Hilton?
Andrew? Yes, yeah. I'm right here. Nice to be here today. Thank you for the introduction. Thank you for the opportunity to speak to people today. I'm talking from Ontario, quite close to Penetanguishene today, where there is a bit of a storm, thunderstorm closing in. So hopefully Wi-Fi will hold out and we'll stay together for the hour. So I'm going to talk about domestic violence, risk assessment and management with a focus on risk needs responsivity approaches and the implications for domestic violence treatment. As mentioned, I am an author of the Odara. I do receive royalties from the book that contains the scoring guide. So I'm mostly going to use the term domestic violence today, but I will probably use it sometimes interchangeably with intimate partner violence. So this is mostly, and the research is mostly about men and their acts or patterns of violence against their spouses, their cohabiting partners, their other intimate partners. So today I'm going to give you a bit of overview of domestic violence treatment and the origins of treatment and models and how it's related to the criminal justice response and what we know about the effectiveness of treatment and adherence to RNR principles. Then I'm going to hone in on the three main RNR principles, starting with risk and especially looking at risk assessment and the Odara, then criminogenic needs and their relation to risk and how it can inform domestic violence treatment. And then I will talk about responsivity and the very little that we know to draw from about responsivity in domestic violence treatment. And then towards the end, I'll talk about some other issues, some unexplored things, maybe things to get a little bit of discussion going perhaps in the Q&A time. So I want to start by talking about the growth in the criminal justice response and its effect on domestic violence treatment. Partly I want to give you an overview of this history because the kinds of treatment models that have been used in domestic violence are probably a bit different from what you're accustomed to if you're coming from forensic mental health. So in the 1970s, responses to domestic violence really emerged as a grassroots movement. This battered women syndrome, or the problem of battered women, the term that was used for quite some time. This was discovered mainly as as a political issue, and it was seen, violence by men against women was seen perhaps quite legitimately as rooted in the system of patriarchy and traditional gender roles and the vulnerability of women within traditional relationships. So the interventions then were provided by women for women, and they were focused on providing refuge and safety for the women, but also interventions to try to change men's patriarchal attitudes, and then the violence that supported those attitudes or was supported by those attitudes. By the 1980s, the impetus for domestic violence treatment was coming much more from the criminal justice system, with the advent of mandatory arrest policies, or at least policies that favored arrest when there was grounds for seeing that an offense had occurred, just like for any other offense. So treatment programs began to emerge that were oriented towards providing court-mandated treatment. So program standards were created so that programs could serve this population of individuals who are mandated by courts to take domestic violence treatment. And so these program standards emerged, and that they had a lot of influence on the models that were being used. And there's a lot of pro-feminist influence on these models. So the Duluth model was one of these, it's widely used, widely emulated. It takes a psychoeducational approach to treatment as well as a pro-feminist perspective. It also has this community engagement piece to try to create a coordinated response to domestic violence, so that the criminal justice and treatment services and victim support sectors are all trying to work together. From the 1990s and up till now, there's been more diversification in treatment models. For example, there are models that try to address individuals differently based on what's come to be known as batterer typologies. There are now programs that aim to help men who use domestic violence be better dads. There's also a growth in cognitive behavioral approaches. So the illustration is getting larger because there's been a lot of growth in treatment programs. These are often called battery intervention programs, especially in the US and the related state standards. A recent article identified that there were over 1,500 different types of battery intervention programs in the US. Now, Canada has followed after the US, becoming later in developing programs. There's been more of a multidisciplinary approach. In Ontario, we primarily have a model called the Partner Assault Response Program, although there are other programs as well. Actually, I would say, I think the literature, even up to very recently, an article just came out this week by Tara Richards on state standards on domestic violence treatment. There does seem to be a lot of blurring of programming now. And based on my understanding, it's unlikely that a program might use a clearly pro-feminist approach or a strictly CBT approach and not some combination of it. Excuse me. So, knowing that, you might not be surprised to see that domestic violence treatment effects tend to be small and non-significant. So first of all, most domestic violence treatment programs are not evaluated, and the evaluations have not used well-controlled designs. This 2005 meta, this figure shows the overall effect on official recidivism for quasi-experimental studies that had a comparison group. The effect's about -0.1, not significantly, a not significant result. Fader and Wilson also show similar figures for victim-reported outcomes and for different designs. And obviously, when the comparison group includes treatment dropouts, then the effects appear larger. So what about RNR in domestic violence treatment? So I'm going to assume a lot of familiarity with the risk needs responsivity model. For risk, we want to assess risk of the individuals, and we want to match the intervention they are given according to their risk. So Richard's new article observes that most states in the US do mandate the use of a risk assessment. But in general, the literature is showing that treatment is not really prioritized well according to risk. Often treatment programs are the same length, the same content, regardless of the level of risk. Now, of course, in Correctional Services Canada, where there's much more attention to the RNR model, we've seen some reports of medium intensity and high intensity domestic violence programming that appears to be promising. For criminogenic needs, we want to target those criminogenic needs, those treatment needs that are associated with risk of recidivism. And we see that some programs for domestic violence are targeting things like substance use, or they're focusing on improving marital and family relationships, communication, or conflict management skills. But often treatment is not conducted with criminogenic needs in mind. And in fact, these two particular needs are quite controversial in domestic violence treatment and have been used as exclusion factors for treatment. Just as is sometimes substance use is used as an exclusion factor for women who have been victimized accessing shelters. So it's definitely an area that needs to be, we're not doing very well in terms of adherence with the criminogenic need principle. And I'll say more about this when I focus in on criminogenic needs. With respect to responsivity, we want to use the most effective treatments based on the available evidence and based on individual characteristics. Well, as I've mentioned, we have a variety of different treatment approaches. There's a lot of blurring of treatment approaches. They tend to be quite eclectic. And many programs are one size fits all, especially in state standards that require a specific program length, such as every participant has 20 weeks of treatment. So there's very little adherence to the responsivity principle overall. So this 2016 article, and I'm drawing some of this from, is by Raddatz and Wright, and it essentially presents a report card on the domestic violence treatment field, and was one of the first to really look at it from an RNR perspective and look for areas of improvement. And I actually have this article to thank for connecting me with Dana Raddatz and what's become a really good working relationship as we've explored exactly some of these issues in our research over the past few years, which I'm going to be sharing with you next. I've also written a couple of chapters on this theme now with Liam Ennis, the Forensic Behavioral Science Group in Alberta, and I'll credit him with some of my thinking around how the RNR can be applied to domestic violence risk assessment and especially threat assessment and risk management. So domestic violence treatment effects appear to be stronger with RNR adherence. This is a more recent analysis of domestic violence treatment evaluations. Excuse me. This is actually a study that I wanted to do, but it seemed really difficult to know from the publications available exactly what was done in a lot of the treatment programs that are being offered. And so, it's really kind of difficult to evaluate adherence to RNR principles. Well, Travis and her colleagues managed to do it. They did a careful job, but you can see that they sometimes struggle to know exactly what was being done and how to determine adherence. So they used a pretty simple approach to determining adherence. They gave up to 3 points for each program based on the evaluation. There was 1 point if the intensity of the treatment was matched to the individual level of risk, and in most cases, some kind of attempt to assess risk, some kind of attempt to estimate whether the risk was medium or high in order to allow people into programs was being used. They got a 2nd point for if there was any process of attending to criminogenic needs, but most studies did not appear to report this. And then a 3rd point for any effort to enhance treatment responsivity, such as adapting the style of treatment to individual learning styles and so on. And in fact, only 4 studies that were evaluated use an entirely one-size-fits-all approach. So scores of 3 out of 3 meant, yes, they were adhering, and 2 out of 3 meant partial adherence, and 1 out of 3 or 0. 1 or 2 out of 3 meant partial adherence, and 0 meant no adherence. So in general, the summary here, the takeaway is that the more adherent the programs were, the stronger the effect of treatment seemed to be on domestic violence recidivism. And this was for studies conducted with a short-term follow-up, I think 1 year or less. I think there were 8 studies in this comparison, and then there were 6 studies with follow-ups of 1 to 2 years, where the adherence effect is smaller, and only those with full adherence showed a significant treatment effect overall. And there were 3 studies with follow-ups over 2 years, so they're pretty short follow-ups here. Of the 3, there was only 1 with full adherence, and again, the effects. Now I want to take a closer look at each of the 3 main RNR principles one by one. So for risk, the first look at risk in domestic violence research was in terms of attempts to classify men who perpetrate domestic violence into different types. There's not been as much research with women, so I will be focusing on men here. So the main finding from typologies will not be a surprise to those of you who come from a forensic mental health or criminology background. Most of the different approaches to typologies identify a generally violent or generally antisocial group that is usually a minority of the sample, but responsible for a disproportionate amount of domestic violence and its severity and its recidivism. So again, not a huge surprise, but if you keep in mind that the roots of domestic violence research are not in forensic mental health, they're not in criminology. And even to be fair, for a long time, criminologists and criminal justice professionals treated domestic violence like it was different from general criminal behavior. But the more research we do looking at other outcomes among men who use domestic violence, the more we see that, especially within the criminal justice system, we're capturing a very generally antisocial type. People have approached apologies in different ways, sometimes to do with the nature of the violence, the pattern of the violence, the individual's emotional state when committing violence, different combinations of those. And I think they come out with a lot of overlap if you look at who they're identifying through these different typologies. So there's been a type of violence identified that is called intimate terrorism. This is in contrast to sometimes mutual low-level conflict. And it seemed to me that our generally antisocial pattern is responsible for more of this intimate terrorism. These individuals, their violent behavior also tends to occur randomly or appear to be random, rather than this cycle of violence that was used to describe domestic violence for a long time, where there's violence followed by a honeymoon phase, followed by a build-up phase. It seems to be more just random to the, as it appears to the person who's being victimized by the violence. There's also found to be a type 1 individual or group with their heart rate goes down when they're engaged in interpersonal conflict. And I'm kind of thinking that this is tied with a general antisocial type as well. So there's been lots of really, you could say, psychologically meaningful approaches to risk, evaluating risk through the typology literature. I think that typologies were in some ways the precursors to structured risk assessment, although they still have lots to inform us about risk assessment and management. There are now several validated structured risk assessment tools available. I've listed here the most widely used, widely validated tools, both actuarial and structured professional judgment, or SPJ. There are also many newer ones appearing all the time with some evidence that they can predict domestic violence, sometimes other outcomes as well. There's the VP Safer by McEwen and others in Australia. And there's new actuarial work out just recently by Chris Henning and others in Oregon. I'm not going to go over all these tools today. I'm going to dive into the Odara and how it can support RNR adherence in domestic violence risk assessment and management. So I'm going to give a brief overview of the Odara and what it does for now. It is the most widely used domestic violence risk assessment tool in policing services and correctional services in Canada. It's also incorporated into criminal justice policies and legislation in states in the US. Was created by me and my colleagues in penitentiary together with the Ontario Provincial Police back in the early 2000s, which seems like a really long time ago now. Our focus at the time was on violence by men against female partners, and that was because of the policing priorities following a number of high-profile domestic murders of women by men, and also just the male to female aggression far outnumbering female to male aggression or other gendered relationships in the police records. So we created the Odara from research using police records and retrospective follow-up. We did the first construction with 589 men, and we did a ragged follow-up of average 5 years. We coded a lot of information that was available in the police files and related records, and we did a hierarchical binary logistic regression analysis to identify the most consistent, strongest predictors of domestic violence recidivism. And our definition of recidivism was a new domestic assault recorded in police records or a charge. So this research resulted in 13 items. We then made binary yes/no items if they weren't already. So scores range from 0 to 1. And then we created 7 risk categories or risk bins. Most of them were based on individual scores, but the higher scores were less common, and we collapsed the higher scores for the 2 highest risk categories. Tests of predictability, though, have usually been based on the full score. So for effect sizes in construction, we had an AUC of 0.77. And in our first cross-validation, using 100 similar cases, the effect was still large despite some shrinkage. And depending on how you want to define domestic violence recidivism, we found AUCs up to 0.8, but meta-analyses put the effect size in the middle of the medium range. Now, the current published norms that appear in the recent book, they're based on the police incident reports from the 1990s and the follow-up into the early 2000s, based on over 1,400 cases drawn from the same police databases in Ontario and the Greater Toronto area. So this is from raw observed data. And in training sessions, I would always say that these numbers could be different in your jurisdiction, or if you define domestic violence recidivism differently. For me, the percentiles have always been the more important piece of information. But recently, learning a lot about standardized risk levels, and I'm working on developing standardized risk levels for the Odara with the help of Carl Hansen and a group of colleagues. That is to come. Not for today, but stay tuned for that. With respect to inter-rater reliability, in our initial research with research coders and with police officers, reliability coefficients were 0.9 and above. This has also been true for assessors in our in-class Odara training. With our new online training, it's more randomized. There's no going back to correct things on the last case if you change your mind. The average reliability has come down a bit to the low 0.8. This is based on about 1,000 trainees a year who use the online Odara program. This study of reliability in this table, this is from data scored from threat assessment files in Alberta, which is from a study that I've been part of with Sandy Jung and Liam Ennis and Kevin Nunes and Anna Pham, sorry. So in that study, the reliability on the total Odara score was 0.84. And you can see from this table, there's some difference across the different items. There's also some challenge with variability so that we had extreme frequencies in some items. So we also looked at the percentage agreements for the specific items, which range from 69 to 97%. So this figure is just a visual illustration of the effect sizes in terms of AUCs for Odara validation studies. And these particular ones are all based on male samples and domestic violence outcomes, I think official data outcomes for all of these. The darker square represents the AUC for the construction sample, 0.77. The striped parts of the bars represent 10 published and unpublished replications by authors, not including me, but including a very recent study by Hegel, Pelletier, and Over, conducted in Northern Canadian sample, predominantly individuals from Indigenous communities. And they reported an overall AUC of 0.62 for domestic violence recidivism. The plain white areas are 6 published replications by me and my colleagues. And I've included a recent study that I've published with Dana Raditz using her data from a US sample where we had an overall AUC of 0.59. And here's more detail of the results from that policing sample from an upstate New York region. So we found that we had to modify the Odara. There was a couple of items that we couldn't score. So of an 11-item version of the Odara, we found significant predictive accuracy for domestic violence as well as other outcomes, any violence and any recidivism. So we actually found that we had relatively low Odara scores based on the information that we could obtain from the police reports, but we found relatively high recidivism rates in a 2-year fixed follow-up. So our domestic violence recidivism base rate was 35%, and for any recidivism, it was 68%. So we found poor calibration with the published Odara norms. So we're finding higher recidivism rates overall, and different calibration at the different levels. So that takeaway from that was, although we found reasonably good predictive accuracy, we realized that we need to create new standards for interpreting the Odara. And that's part of the risk level work that I'm embarking on. For now, though, this is the interpretation data that we use. This figure is based on the original construction and cross-validation studies. And it shows that for every increase in Odara score, there's an increase in the percentage of men who reoffended, and that there are relatively few men at the extreme low or extreme high scores on the Odara. So we've got a sort of blunted normal distribution. But when police are scoring the Odara live in the field, so to speak, the distribution seems to be shifted to the higher ends. And I think this is because, based on other research about from Marianne Campbell, about when police are actually using the Odara, they tend to score it more when they're deciding to lay charges or referring the case on to a higher risk management protocol. So these tend also to be the higher scoring cases. So this is something that my colleagues and I will also be looking into soon. In the meantime, calibration notwithstanding, I believe that the Odara can contribute to the risk principle in domestic violence treatment by helping programs identify the highest risk individuals who should then be prioritized for best available, most intensive treatment, more modules, more hours, whatever it is you have, and more focus on crimogenic needs. And if in a particular region, you know the distribution of Odara scores in your target population, then you can also plan for the resources that will take and which Odara score you're going to make as your cutoff for your high-risk protocol or for your most intense treatment. And depending on what resources you have and what proportion of your target population you can afford to give the most intensive services to. So moving on to the need principle. I'm assuming some familiarity with the central 8 crimogenic needs. And of course, I encourage program providers, treatment providers, to assess these needs prior to any treatment programming. There is evidence that some of these needs are related to domestic offending, but not all of them. So here I've just tried to align each of the needs with elements that could be part of an intervention for domestic violence, but really this is just coming from the general offending literature. So for antisocial behavior, as I've already described with the topology research, antisocial behavior is a risk factor for domestic violence. Obviously, criminal history can't be changed, but interventions can aim at developing non-criminal responses to risky situations with a focus on the domestic behavior, the domestic offending behavior. For antisocial personality, there's a growing literature suggesting there's a potential for treatment, including problem solving or emotional regulation, which is being used in the offending field generally. This is not my area of expertise, but I do know the literature that shows that anger appears to be elevated in men who use domestic violence. Anger management and emotional regulation of anger has been a popular target in domestic violence treatment, but not without controversy, although it appears that it might be consistent with RNR. For antisocial cognitions in domestic violence, this would translate into attitudes that are accepting of violence or attitudes that evaluate the violence as justifiable, and attempts to change men's attitudes towards violence and towards women and domestic violence in particular. This was the focus, or has been at the focus, of a lot of early and continuing models of domestic violence treatment. But actually, there's not consistent evidence that attitudes about domestic violence are related to using domestic violence. And treatment programs that aim to change domestic violence attitudes have not shown strong effects on reducing domestic violence recidivism. Now, there may be issues around how we're looking at attitudes, what kind of attitudes we're looking at, and so I'm hoping to explore that with some of my colleagues in the future as well. Having antisocial associates. So this is an area where there's very little information when it comes to domestic violence. There was some early work in the 1990s on the male peer support hypothesis, but this does not seem to have translated into risk assessment and treatment. When it comes to substance use, now this is a widely recognized criminogenic need in the general offending literature and also in the domestic violence treatment field. However, it is controversial for a number of reasons. One is that the grassroots approach sees an emphasis on substance use as providing individuals with an excuse for their behavior, taking away the responsibility, whereas the pro-feminist models of domestic violence who focus on individuals taking responsibility for their actions. This may be less true in the more recent CBT-focused models. But another reason that substance use has been controversial is that there was some really neat research about 15 years ago that found changes in daily drinking behavior were directly related to the use of violent behavior. But there turned out to be some very serious research ethics problems, and the veracity of the research is questioned. And I think it might have ended up setting the field back a bit in terms of what we can research in looking at substance use as a criminogenic need. For problems in family and marital relationships, seems a bit of a no-brainer for domestic violence. Both men and women who use domestic violence say that communication problems, wanting control, or experiencing jealousy in their relationships, these are problems that contribute to their violence. And sexual jealousy especially is thought to be a risk factor for intimate partner homicide. Now, there are interventions to reduce interpersonal conflict and improve skills in these areas that are typically recommended for relationships that are having trouble, not necessarily with violence. The evidence that these approaches are effective as an intervention to reduce domestic violence is so far thin on the ground. And this is also true for problems with school or work and lack of pro-social recreation. The research just isn't there. It's not clear, it's not consistent on whether or how these treatment needs relate to the risk of domestic violence recidivism. There's still much more work that we can be doing in this area. I want to show you some studies that I've done of criminogenic needs and domestic offending in forensic and policing samples. So what we're seeing is that men with domestic violence histories have more criminogenic needs. This particular figure is taken from a secondary analysis of men in forensic assessment. Typically, historically, about 50% of men who come through our forensic assessment program go off into the criminal justice system, and about 50% stay in the forensic psychiatric system. So it's partly representative of both, but certainly more in the area of those who may have more psychiatric problems. Only a few studies have actually intentionally examined criminogenic needs among men who use domestic violence. And I don't think there's been anything with women at all. So this study did not intentionally set out to measure criminogenic needs in this subgroup. We went back and identified the subgroup later. And what we see, if you look at the darker colored bars on the left, this represents men who had a history of domestic violence. And these men, there were significant group differences across all the 6 criminogenic needs that we could identify in this database. And in most cases, the men who had a history of domestic violence were more likely to have each need than men who committed violence that wasn't domestic related, or men with a history of only non-violent offenses. Substance use, poor relationships, and problems at work and school, these were the most common criminogenic needs. We also looked at a couple of non-criminogenic needs, mental disorder, physical health problems, and we found no significant group differences. Now, in routine police cases, now this is looking back at the Odara construction and cross-validation samples and identifying criminogenic needs in that database. We found that men with higher Odara scores had more criminogenic needs. Again, secondary analysis, and we were only able to identify 5 criminogenic needs. Substance use, poor relationships, and work-school problems were again among the most common criminogenic needs. Antisociality was more common in this sample than in the forensic sample, but I think that might have been because we used a different criteria just because of the different information that we have. Odara scores correlations with each of the criminogenic needs is shown in the middle column of data in this table. And this shows that every criminogenic need that we could measure was associated with a higher Odara score. So that the number of criminogenic needs also had a pretty strong correlation, a medium effect with the Odara score. The number of criminogenic needs also had a small correlation with domestic violence recidivism. I don't think that's shown in this table, but if you look down the last column, you can see that each individual criminogenic need, except marital or family problems, was significantly associated with domestic violence recidivism. Now, again, using the policing sample, this table shows that the number of criminogenic, it shows the number of criminogenic needs as a function of the Odara score, which we've divided into 3 categories. This was based on approximate thirds of the distribution of the men who had been charged for domestic assault. We had made this 3-category distinction in a previous article. We were just trying to illustrate for domestic violence treatment providers how you could use the actuarial properties of the Odara to prioritize individuals for treatment. So here's just for illustration. It's not how I'm suggesting we should communicate risk. But this table shows that for the middle third of cases, the mean number of criminogenic needs was 1. For the lower third, it was about half that rate, and for the upper third, it was about twice that rate. So criminogenic needs significantly increased with each increase of what we call Odara treatment intensity category. Not to say that the Odara has ambitions of being a risk needs assessment tool, but it does add a little weight to using the Odara in domestic violence risk assessment and management, as the men with the highest risk also turn out to have more criminogenic needs. And again, this might not be a surprise to those of you who are familiar with the RNR literature or working in a forensic mental health setting, but it has taken the domestic violence field a while to come around to looking at the need principle. And responsivity has been even slower. So all I can offer here in terms of the responsivity principle in domestic violence treatment is to point to other areas that identify different characteristics of individuals or cultures that may have relevance for how treatment is provided and how risk is managed. So if you look at treatment attrition, for example, the predictors of treatment attrition in domestic violence have a lot of overlap with the predictors of domestic violence recidivism. So these include younger age, antisocial personality, substance use, prior offending, voluntary referral to treatment, unemployment, lower income, lower education. So when we see these characteristics, we may be needing to pay more attention to motivation for treatment or methods to keep people in treatment if that's the intervention that we're working with. In terms of general responsivity, we're still working on what are the most effective approaches for domestic violence treatment specifically. Offender typologies that I mentioned earlier, I think these can be seen as responsivity characteristics. So the typical, if you like, 3-type typology gives us men who offend against family members only, those who are generally antisocial, and those who are considered dysphoric, potentially having borderline personality disorder. And looking at the level of type of violence and the level of psychopathology, these can all be seen as cues to different ways that treatment or other interventions may be delivered and sustained. In terms of culturally competent care, so this has been an issue raised in the domestic violence treatment literature for some time, especially with respect to racial minorities and having appropriate treatment leadership and treatment modality. The issues of race and gender in risk assessment, especially with respect to the Odara, is something that I'm currently looking at with my colleague Dana Raditz. Other research have been looking at domestic violence within a context of what's called honor killings and the important cultural or religious issues around that we need to be sensitive to in attending to risk assessment and management. And in Canada as well, I mentioned the partner assault response model in Ontario, but there are a variety of different approaches, including interventions that have been designed by and for people in our Indigenous communities. So to finish off, I just want to talk about a few understudied issues, areas for where research is growing, where there's some, a lot of new interest and perhaps expansion in the future. So first thing is coercive control. So what is meant by coercive control? It's about the non-physical acts that an individual might do to attempt to control their partner and prevent the partner from leaving the relationship and doing the things that they want them to do. So this can include a lot of monitoring, checking use of the internet, restricting access to other technical or face-to-face contact with friends or family, threatening to take the children away, restricting access to money, threatening or actually abusing pets or other animals. Is this a risk factor for domestic violence recidivism? It's certainly thought to be a risk factor for domestic homicide. We want to see more research looking at this, although of course statistically, fortunately, homicide is a rare event and therefore difficult to actually identify predictors for. But is it a risk factor for domestic violence recidivism and its severity? Is it, I wonder, a responsivity factor? So if an individual is using monitoring and threats and abusing pets, should they be a higher priority for the same kind of treatment or other risk management that we offer to all our riskiest individuals? Or should treatment be delivered in a different way? Or are there different aspects of behaviors that we need to approach in a different way? So is this tendency to try to control the partner a responsivity factor? Early treatment programs, the battery intervention programs from the 70s, 80s, they were all about men's controlling attitudes. But they applied that model to everybody who was in treatment. Now that domestic violence treatment is moving more towards CBT and other techniques, is this approach going to be as effective for men who use coercive control? Or is the concept of power dynamics and power of control in relationships something we need to reconsider for men who use coercive control? And this has been especially examined among men, as for all the research that I've been talking about today. Much less is known about women who use domestic violence. A related issue is non-violent outcomes in domestically abusive relationship. In a study with Angela Eek in 2016, we found that the Odara predicted a whole range of violent outcomes, including domestic violence specifically, and the predictive accuracy for domestic outcomes actually increased when we included non-violent offending that was against intimate partners, such as violations of restraining orders and break and enters and so on. But in some other studies, the Odara doesn't perform as well when the outcome is broadened. There were certainly studies conducted in Alberta by Sandy Jung and Mark Oliver looking at other like non-domestic violence outcomes, and we've been doing the same with Sandy Jung's group looking at the threat assessment data. Others are expanding outcomes in a different way, looking at, okay, not just intimate partner violence, but also violence involving children and parents or siblings, so on. And with all the growth in different tools, I kind of empathize from the policing perspective, because the police are the gatekeeper into the criminal justice system, and now they're the gatekeeper into the whole risk assessment and risk management system. And there's so many tools that I can understand that there's some need to push back against that, because when an officer is attending a domestic, a situation at home, there could be any one of a range of different kinds of relationships involved in violent or abusive behavior. So that intimate partner violence is just one piece of all the offenses that an officer may need to be evaluating. So there's a real desire to have tools that deal with all kinds of family violence. And I think that's something that we need to address somehow. And I think we want to identify other risks of harm. And we've actually found that the Odara is associated with child abuse as well. But I wonder how much we can reconcile this broadening, this need for a one tool fits all approach with a valid application of the risk principle. And finally, where does dynamic risk fit? There has been some debate, for example, that structured professional judgment tools are better for risk management because they contain dynamic risk factors. I believe, though, that is actually an empirical question, and that the empirical research must start with measuring risk factors at more than one time, and testing whether change in those risk factors improves prediction, and whether change in those risk factors improves over the original first assessment of risk. And I love that this research is being done in the general offending and violent offending and sexual offending literatures. But this research has not been done for domestic violence outcomes. So we're really not ready to talk about dynamic risk of domestic violence recidivism. Now, I noticed recently that, and I'm not sure if I'm saying these names right, but Joseph Simpson and Joshi and Polishek tested another actuarial tool, and a tool that was for police, that designed to aid police decisions within a 3-day time span, looking at intimate partner violence and other family outcomes more broadly. And they found generally small or non-significant predictive effects, but prediction improved with longer follow-ups. So currently, with our current ability, identifying risks, our ability to identify risks improves when we take a long-term view. And I think we're still a long way from assessing imminent risks or dynamic risk assessment in domestic violence. And in my view, in conclusion, using an actuarial tool, an actuarial approach like the Odara, and applying the RNR principles and adhering to the risk, need, and responsivity principles is the best approach we've got so far for domestic violence risk assessment and management. In the slides, if people want to access them afterwards, I have included details and links to the main articles that I have referred to today. And there's a longer reading list for those of you who are really keen. But for now, I'm interested in hearing about your questions and any discussion.
Thank you so much for that talk. Wonderful talk. Very, I'll be thinking about it for some time. So at this moment, I'd like to open the floor up for questions. The preferred method is if you just unmute your mic and then ask your question just audibly. That's definitely the preferred method. But if that doesn't work, then you can please feel free to just type in the chat. That will also work. And certainly, now that being said, I have a question that was sent to myself here. Can I ask Zoe if she can talk about any findings that relate to the Odara to severity of intimate partner violence? In essence, yes, can you provide comments with regard to that?
Sure. I mean, the brief answer is that in a few studies, especially, for example, in the original construction and cross-validation studies, we have found that a higher Odara score is correlated with severity of the domestic violence recidivism in terms of the number of new assaults, the injury in new assaults, and the seriousness of charges in new assaults. So this is one of the reasons, if I can digress a little bit on this, that my argument for how we approach domestic homicide begins with using an assessment of domestic violence risk, because with that we can identify some of the more serious cases. I don't know if this question is kind of leading to the issue of domestic homicide, which is really a very, very difficult issue to address with risk assessment. If that answers your question.
Okay. Any other questions for Dr. Hilton? Please don't be shy.
Hi, I was just wondering if any of the research that you've been looking at looks at executive functioning skills and the impact of programs in addressing executive functioning skills and the particular impulsivity and reactive and poor social perception.
None of my research has looked at this. I'm not familiar with much research out there looking at executive function. Some of the typology work has tried to set kind of domestic, kind of emotional reactivity and cognitive reactivity in the context of having an interpersonal conflict. And this is where we're finding things like the type 1 that where the heartbeat relaxes during conflict. But I'm afraid I can't speak much to the executive function with respect to domestic violence research out there. I think we may see that more in the literature looking at different types of violence as well, whether it's reactive or more instrumental violence as well. So we may see some work there.
Thank you.
So perhaps this is one of those 60,000-foot questions that I would have for you. If you had unlimited resources right this moment, what would you think is the most pressing thing that we need to study right now?
I can tell you what is the most pressing thing that I want to study right now. I think there's a big lack in the domestic violence research and how much we can do in the domestic violence field compared with general offending, because we lack large databases, including in Canada. Most of the research that we're pulling these studies from is from frontline policing records management systems, where they're not necessarily recording risk assessment scores, where researchers were still going in and coding things by hand and coming up with samples of a few hundred, compared with studies for things like the Static 99, where you can use correctional services data and you can have very large databases. So there's very little opportunity to get into the nuances of domestic violence risk assessment and to be able to evaluate our risk management for domestic violence, because we're looking at such small samples. And police officers, for example, and correctional services have been using these tools for some time. They've been, over the past 20 years, rapidly and consistently trying to improve their responses to domestic violence. And yet we don't really have a sense at all of how effective the police response is, because we're always dealing with very local, very small samples. And so this is what I'm hoping to work on next, bringing together colleagues from different regions and expanding our access to larger data sets. So that's my wish.
Okay, thank you. We have time for a couple more, if anyone else would like to ask.
And if people are thinking of questions that pop up later, please feel free to shoot me an email. I'm happy to respond or send you the slides, whatever you would like.
Yeah. Okay. Well, I want to thank you, Dr. Hilton. A wonderful talk. We have loved having you here. And we appreciate your time this morning and the effort that you put into this presentation. Thank you so much for your willingness to be here.
Thank you very much for your time, everybody.
Okay, take care.
Bye-bye.